So today I want to introduce an idea that is significant in maternity care, but also across all disciplines of healthcare. And to illustrate this idea, I'm actually going to share a personal story. So as a midwife, my continuing education requirements are across disciplines, including doctors, nurses, and lactation consultants and other kinds of providers. So when I go to trainings, lots of different people are there. I want to share an experience I had as a provider at a 2-day training called Advanced Life Support in Obstetrics. What I encountered at that training is so interesting. There were really nice doctors and certified nurse midwives who were the instructors. They wanted to share their skills and their knowledge, and they wanted to provide good care to their patients. I was the only home birth midwife there, but there were student doctors, nurses, and other doctors who were there to receive the training. I did not feel like anyone was hostile toward me as an out-of-hospital birth provider for being at that training. Maybe they actually thought it was a responsible thing for me to do, to be at the training. However, there was a throwaway comment at one of the sessions that I can't forget, and it was, "You know what happens to those patients who bring us a birth plan?" And rippled around the room was a response, "C-section, C-section." There was a lot of impatience and disdain for the idea of a birth plan at that class. Really, everything else I learned was fantastic, but today I just want to talk a little bit about that birth plan idea. So let me give you a little bit of a back history. In the 1970s and 80s, there was some backlash against interventional birth in the hospital, which was the common routine experience by most women in the United States. Informed birthing women started to formulate a birth plan, which they would bring to their doctor or occasionally a midwife. That way they could talk about the different interventions that they did not want to have for their birth. In the medical culture of the late 20th century, a lot of doctors felt like they were being dictated to on how they could practice, and they felt frustrated with their patients for trying to tell them what they didn't want to do. Especially for very detail-oriented planners, the 80s and 90s birth plan evolved to be this 4 or 5 page document with lots and lots of detailed specifics about how they wanted to dictate their birth to go. The idea is that the more specific someone tries to be about how their birth is going to go, the more likely they are to have an intervention or many interventions. My side comment on this perception is that it may have a tiny grain of truth, but it is so paternalistic and disempowering to patients to have a knowing nod when they bring a birth plan instead of having a conversation with your patient. So as the lone home birth midwife at that training, I found myself pointing out just that when patients bring a big detailed birth plan or care plan to their doctor, they're trying to have a conversation. They're trying to start a conversation when they feel rushed and not heard. I commented in the course comments to please not feed the attitudes of new doctors and residents disdain for their patients who bring a request for preferences. For example, a birth plan. I share this story not to demonstrate bad doctors. They were excellent doctors. I'm sharing this story as an example to indicate that healthcare is in a weird place. People are needing more of it than ever, but they're not happy with what they're getting. They feel ignored and not listened to. They feel like they have a lack of time to ask questions. What many people don't realize is that their providers are just as unhappy with the care that they are giving because they have dictated practice models that they're supposed to be following. They're working under harder and more complex circumstances than a generation ago. They spend more time caring and feeding for electronic health record systems than actually with their patients. They feel like their hands are tied by hospital policy and health insurance policies. They're experiencing record levels of burnout, loss of empathy, depression, anxiety, and even suicide. and it's definitely affecting the families and loved ones of our healthcare providers. That sounds bad. But I am actively following the stories of multiple programs and people around the country and around the world who are trying to make improvements. Today I want to share 3 of them with you. The first is a family physician from Oregon by the name of Pamela Wible. She tells her story in such a way that she is a microcosm of this phenomenon of bad health care. She practiced for several years in a large family medicine practice, and finally, in a state of burnout, she left and tried to figure out what she was going to do next. So she sent out questionnaires to her community, and she held town hall meetings where people came and told her what they wanted healthcare to look like. She implemented a large percentage of the community-dictated preferences, and she has been running a family care practice in Oregon since then. Also, as a result of her evolution and efforts, she has become a repository of data on physician suicide. She's become a support person for almost suicidal physicians and their families. She started making a list of doctors who died by suicide because nobody else was. As a result of all of this, she has become a national and maybe even a world-level speaker at medical conferences, in front of groups of medical students, and she has done TED Talks. And she is still working on evolving the best ways to share her message with the world. She's a very interesting person to follow. The second effort I am following is that family medicine is trying to think of different ways of paying for health care. And one model of care they're looking at is to use health insurance to pay for high-cost care, such as hospital stays, surgeries, and for regular routine family medicine care to have a membership with your doctor where that provides a regular income to your doctor, and the doctor can also choose what size of practice he or she wants to have. Work part-time or full-time, have just 100 patients or 400 or 500 patients. And they can also choose how long of appointments they set, and generally have a lot more autonomy for themselves over how to organize their practice. And the healthcare model is called direct primary care. It's very interesting to me because it looks remarkably like midwifery care in a home setting. You may have experienced your doctor switching over from a regular medical practice to a concierge care practice. The alternative may have been that your doctor was just thinking, I have to do this, or I have to leave medicine because it's not sustainable for her family and for her own health care. Most doctors really are interested in providing excellent health care and love to take care of their patients. They really do. The third effort I am following is organized by Dr. Victor Montori, a professor of medicine at the Mayo Clinic. He has a TEDx talk, a book, and a proposal for a patient revolution. In his video on shared decision making, he says, anything that enhances transparency and accountability in healthcare can begin to reduce corruption in healthcare. Dr. Montori shares information about his nonprofit organization, which can be found at www.patientrevolution.org. And there you can find information about and tools to implement shared decision making, a way of involving patients in their own healthcare decisions. I'm going to include links to all these resources below. And for this video series, I'm going to spend time discussing the principles of shared decision making, autonomy, self-advocacy, informed consent, and the process of decision making as a person who requires healthcare from time to time. Good information that you can use regardless of the medicine that you need. My perspective and training is, of course, maternity care. And maternity care is a large percentage of healthcare by far. But those principles of autonomy, choice, and informed consent, and the process of making decisions are transitive across every kind of healthcare that you might need. The good news is there are people trying to transform healthcare at every level. Homebirth midwives are just one group, which is what I do. These other examples are people who are working in their circle of influence to try to improve their experience as healthcare practitioners and your experience as a patient, as someone who needs healthcare from time to time. The end goal for all parties is to empower you to take the reins of your own healthcare and be able to listen to your doctors, nurses, chiropractors, and other practitioners as advisors, and in the end, make your decision yourself. So look for upcoming videos exploring the topics of autonomy, informed consent, and shared decision making, and stop by on the first and third Tuesdays for new videos in this series. Thanks for stopping by Midwife Becky's Homebirth channel. Have a great day.